Hello from the North Shore of Chicago. I'm Dr. John Erwin. I'm a general cardiologist and I serve as the chair of the Department of Medicine for North Shore University Health System. And I'm a professor, clinical professor at the University of Chicago Pritzker School of Medicine. I'm very pleased to be here with this great group of people today to discuss with you some of the challenges in cardiovascular care delivery when COVID-19 hits. Obviously, we were dealing with things that couldn't have imagined would have been our pain points when this all started out. Who would have thought that we would have difficulty in obtaining proper amounts of personal protective equipment, that we'd be able to have an adequate supply chain of having this regularly as we were dealing with this respiratory pathogen, as well as the difficulties that we've had in testing, both in terms of getting the testing right, as well as having reagents and the various equipment necessary to do the testing on the scale that has been necessary to help us to take care of our heart patients. And then obviously because of some of these issues, we delayed care from our own operations in certain circumstances, but then the patient factors also came into play as the concern of coming into healthcare systems became a bigger and bigger issue with patients as they quite grew fearful of this disease. So who would have thought those months back that we would have had to even go back and spend all this extra time learning even simply how to don and doff our protective equipment the right way. So each of these things can be major determinants in terms of delays in care, in terms of barriers to care for our patients that we've all had to muddle through and learn how to deal with. Beyond that, we're taking care of a new disease, one which we're trying to learn new things about each and every day. We're actually living in the science of this disease. And it's exhilarating on one point to learn about a new disease, but it's also terrifying at another point because certainly as cardiologists, we like to know the evidence base behind what we do. And we're having to build the engine on the airplane as we're flying it right now. Beyond that, having to deal with the rumors and the evidence issues that we struggle with, and then the public fear, or even lack thereof public fear in some instances, has led us down this path that has been quite hectic and chaotic in some cases. Thankfully, we're starting to develop some order out of all that, and we will certainly learn and grow better and do better as time goes along. But certainly lots of barriers to care, even the basic types of things that we need to do. From the standpoint of what we like to get to, the evidence that we know, we've clearly seen an overlap in the types of patients that we care for and the comorbidities that our patients typically have, especially as it pertains to mixing it with this COVID-19 infection. Clearly, we have seen the after effects of people who have underlying coronary disease, hypertension, diabetes, and have seen those having been more disproportionately affected by this viral illness and having a heavier burden of the more severe illness cases that we've seen during the course of this. We also know that any time that a respiratory viral season comes along, that we obviously do see increased cardiac injury with the inflammation that occurs in that situation. We do think that now there's probably some evidence of direct infection of the heart with myocarditis, as well as indirect issues related to any of the systemic inflammation that we deal with. Acute coronary syndromes certainly can increase, especially as it pertains to thromboembolic events, which we have really learned a lot about through the course of these first several months of the COVID pandemic. I will leave that going into the deep dive to other speakers that you will hear from today that have great expertise in this area. We've also dealt with rhythm issues that are associated potentially with myocardial injury, with myocarditis, as well as those that may have occurred as we were muddling our way through with how to treat these patients initially with some of the drugs that clearly can have some rhythm side effects. We also early on had some confusion based on the ACE2 receptor and how ACE inhibitors, ARBs, and thiazinolinitides may affect these interactions. Thankfully, we're not finding too much in the way of that, aside from some interaction with some of our anticoagulants, which will be discussed later. Now, again, just to reiterate what we have seen across the world, but more specifically in the United States, that a very significant proportion of our patients that got extremely ill with COVID-19 had underlying cardiovascular disease, hypertension, diabetes, and obesity. And I think that's just a reflection of our society in the United States. Now, we have also seen fewer patients coming in with STEMIs. Most of us would respond this way. If you look at the orange there, those are the number of respondents to this survey that said that yes, the number of STEMIs that we're seeing in our hospitals have most certainly decreased. There has been a small amount that said there's not been any change, a small amount that said there's been an increase, and we'll look into those a little bit as we move forward too. Another survey that was done across Europe revealed that the main consequences of the pandemic, again, were that we were seeing fewer heart attacks. And almost 80% of our respondents perceived that there were a decreased number of STEMIs. And according to them, the number of patients admitted to the hospital had also decreased by 50% on average. So people were staying away from hospitals with significant medical diseases, heart disease being one of them. Now, there were a little over 60% of respondents that also admitted that their STEMI patients were presenting later than usual. And this is a problem to begin with, even in the usual state, pre-COVID. But certainly we have seen across the world that there has still been a further delay, especially when it comes to the barriers and the complications that are occurring, both on the care provider side of the equation, as well as those patients who are needing care side of the equation. And again, beyond that, many of our departments have been impacted by the outbreak of the infection. Almost 70% of the respondents to this survey felt that the cardiology department had been partially or even totally restructured to accommodate infected patients. And that's not surprising at all. I'm actually surprised it's not a little higher than that, to be honest with you. If we do look at the small minority of people who saw an increase in STEMIs coming into their care facilities. Again, this was a very small percentage. Only about 3% of respondents said that it went up. Some said that it was related to health anxiety causing the STEMI. Some indicated that more STEMIs are simply occurring in the situation of the inflammation, et cetera. In this orange, it doesn't project well here, but the orange were more STEMIs presenting, yet with less coronary arterial disease in terms of the typical atherosclerotic burden. So again, there are a fair number of people across the world that were noting that we were seeing STEMIs, but with many of them having no evidence of significant epicardial disease noted. And again, let's just go back to reiterate this fact that when we're looking at the potentials for delays in the care of ST segment myocardial elevation, that those facilities that noted a full change in their country's lockdown tend to have the longest ST segment myocardial infarction delays. Also, those who are admitting more numbers of patients across the way, we're noting that as well. Pardon me. And then beyond that, those that had noted a significant restructuring, either partial or total restructuring of their cardiac unit, clearly saw those delays in care that were occurring. Now, beyond what we're seeing in the coronaries, and we'll talk about the myocardium a little later, there's also concerns about what this may impact down the line in terms of cardiac valves, both as a direct impact potentially of the COVID infection on the endothelium on the valves, and what that may cause as an ignition for what could happen to valvular disease down the line, but also from the systemic inflammatory effects. This cytokine storm certainly can affect the stroma of the heart valve tissue. And there is very significant concern that down the line that we may see some acceleration of valvular heart disease that's occurred. Beyond that, we obviously clearly saw, as it pertains to our interventional procedures with patients specifically with aortic valve disease, that we did have to create some delays in some of that care. And it led to the American Heart Association to put out some guidelines as to how we should manage these patients who are requiring TAVR. Now, I think this makes very good sense to all of us that if it's an emergent and there's cardiogenic shock, acute refractory heart failure, we got to get that patient in, we got to take care of them and do the procedure that's necessary to save their life, Urgent, again, need to do it as soon as feasible, and obviously across the board with appropriate COVID testing and appropriate PPE as indicated. And then in the more elective state where there's chronic angina, chronic fatigue, limited capacity, or the truly asymptomatic AS patient, we may be able to postpone that therapy for a while and have more time to test and make sure that both the patient and the staff is safe as we're going through this. One of the things that we'll point out is that many procedures that start out as elective, meaning something that we could do for 8, 12 weeks later, over a period of time as this is recurring and the months go by, it did cause some delays. And there are people across the country that have reported to me that they did see deaths that occurred from people who, when they presented for evaluation of their TAVI, they were clearly in elective range. But because there was not adequate follow-up, because patients were afraid to come in, we have lost patients to valvular heart disease in this regard. So I think this is a good strata for us to use as it pertains to how we should deal with any type of procedure. We could probably plug and play any of the procedures that we do into this type of a format, and makes good conventional sense with this. What about myocarditis? Well, there's been a lot written lately and a lot of controversy around this. Obviously, the JAMA paper out of Germany caused quite a bit of a maelstrom moving forward. Subsequently, we think that there may be some flaws in the way that was performed. Yet, even with the revisions that have been done in this paper, I don't think there's any doubt that COVID-19 can cause myocarditis, and maybe even at a higher rate than some of our other enteroviruses that we know commonly cause myocarditis in respiratory seasons. The true prevalence really is unknown. There have been several studies that have come out, not any of those with real control or the ability to tease out some of the other confounders. So our true prevalence really is unknown as it pertains to the myocarditis. And we'll still need to have that close follow-up with those symptomatic patients post-recovery. And I'd say we also need to be cautious in our approach to getting patients back to full activity, with the possibility that they could have a myocarditis process going on that could potentially be dangerous to them. I'd say keep an eye on the literature. I'd say also keep an eye on Dr. Vink Murthy on his Twitter feed. If you look down at the bottom here, he's been quite critical of some of the data that's come out as it pertains to CMR data. And I think it's well-founded that we be critical of that data as we're learning. Let's be prudent, but let's keep an eye on the literature as it comes out. And again, I think the key for us here is making sure that we're instructing our patients as we go along, that if they have persistence of symptoms after the acute COVID infection, that they should clearly come back and follow up with us, because we may need to do some further assessment to sort this out. So in conclusion, COVID-19 has clearly resulted in numerous changes to our practices of cardiology. It's affected our people, and that's our staff, our patients. It's affected our processes. It's affected our press. And we need to teach and rebut, and we need to be out there to counteract that data that is not good science. We need to make sure that we're the voices that are heard in all of this. And clearly the basis of all of this is going to be exposure limitation and personal protective equipment, proper use, and adequate supply with that. We'll learn new processes and workflows as we gain experience with managing this. We'll also need to remain mindful that even elective indications for interventions can become urgent and emergent, and it's going to be that much more important that we keep continuous lines of communications with our patients until we can get them back into our practices. We also must strive to educate the public to take heed of their cardiovascular symptoms and to seek help promptly. Obviously, there's a great deal of patients who are having a lot of shortness of breath as they're recovering from COVID. Those patients need to be checked out, probably are going to need a cardiovascular assessment. And then we'll need to continue to see cardiac issues. We will continue to see cardiac issues related to COVID-19, even in the aftermath of the pandemic. So I thank you for letting me spend time with you today. Obviously, we could go a lot deeper with this, and we're going to continue to learn. So stay tuned as we move forward. We will learn more together. Thanks for joining in.